Assalamualaikum warahmatullahi wabarakatuh. Ya. Selamat siang Bapak Ibu hadirin sekalian. Selamat datang di acara Open TB Seminar bertajuk Tuberculosis the Other Pandemic. Sebelumnya saya ingin menyampaikan selamat datang kepada yang terhormat Bapak Wakil Rektor 3 Profesor Hendarmawan. Kemudian yang terhormat Dr. Bhakti Ali Syahbana selaku Ketua Research Center for Care and Control of Infectious Disease atau RC3ID. Kemudian we would like to welcome Professor Reinhard van Krevel and Professor Philip Hill as our honorable guests for today. And also selamat siang kepada Dr. Panji Fortuna selaku narasumber hari ini juga, dan hadirin yang terhormat yang ada di sini dan juga via Zoom. Pada hari ini insya Allah kita akan mendengarkan beberapa topik yang menarik terkait updates di topik tuberkulosis yang akan disampaikan oleh narasumber kita dari dalam dan luar negeri hari ini. Sebagai pembuka, saya ingin mempersilahkan Sabana untuk menyampaikan opening remarks. Monggo, Dok.
Boleh buka masker sedikit. Mohon izin. Biar lebih tenang. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Selamat siang. Terima kasih atas kehadiran dari teman-teman semua di sini. Yang terhormat Prof. Hendarmawan, to our honor guest, Prof. Philip Hill and Prof. Reinhard van Krevel. Ada Prof. Ida di sini, Dr. Rudi, dan teman-teman sekalian yang saya banggakan. Terima kasih. Jadi mungkin sedikit saya memberikan penjelasan tentang pelaksanaan acara ini. Jadi acara ini dilaksanakan untuk mengupdate tentang apa yang kita ketahui tentang tuberkulosis. Kita tahu bahwa tuberkulosis adalah permasalahan di Indonesia, dan Indonesia nomor 3 di dunia atau nomor 2 di dunia dengan tuberkulosisnya. Dan kebetulan ada tamu kami, Prof. Reinhard van Krevel dan Prof. Philip. Mereka termasuk peneliti yang terdepan di dunia dalam bidang tuberkulosis, karena itu kami daulat untuk memberikan kuliah di sini, dan alhamdulillah kita sudah bisa bertemu lagi di sini. Jadi seandainya teman-teman atau sejawat sekalian ada yang ingin ketemu langsung dan ngobrol, silahkan sesudah acara ini. Ini sangat terbuka. Kemudian juga untuk Prof. Hendarwanto, jadi acara ini kita harap bisa dilakukan untuk semua tamu-tamu kami seandainya ke sini, yang ini dilaksanakan oleh RC3ID. Jadi pusat acara ini dilaksanakan oleh kami, tapi kami juga bekerja sama dengan Fakultas Kedokteran dan juga dengan beberapa prodi S2 yang ada di Fakultas Kedokteran. Acara ini dihadiri oleh 4 narasumber. Dari Indonesia kami dan Dr. Panji, dan dari luar negeri adalah tamu-tamu kami tadi Prof. Philip dan Prof. Reinhard. Dan peserta yang terdaftar sampai saat ini mungkin ada sekitar 100 lebih ya, 120-an. Dan yang ada di gedung ini saya nggak tahu, mungkin sekitar 50-60 orang. 200. Ya, terima kasih. Oke, jadi kami berharap sebenarnya acara ini memang kami umumkan terlalu mendadak, mungkin baru hari Senin. Sebenarnya kami juga umumkan acara ini terbuka bukan hanya untuk UNPAD, tetapi juga untuk kita ada jejaring JATSET TB, kita juga ada jejaring peneliti penyakit tropik dan infeksi, dan teman-teman mungkin ada Dr. Ita, Dr. Denny dan kawan-kawan, dan Dr. Panji juga memperluas ke IKM. Jadi insya Allah mungkin dalam waktu yang ke depan kita lebih berdampak lagi dalam peningkatan pengetahuan mengenai penelitian. Demikian saja, mungkin terima kasih atas semua pihak yang sudah membantu, dan terima kasih, thank you very much for our distinguished guests. And mohon maaf, I'm sorry if there is something dalam pelaksanaan ini kita yang masih kurang sempurna. Demikian, terima kasih banyak. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih banyak Dr. Bhakti Ali Syahbana atas opening remarks yang diberikan. Selanjutnya saya undang Wakil Rektor TBM Profesor Dr. Hendarmawan untuk memberikan opening remarks. Mangga Prof. Hendarmawan, waktu dan tempat dipersilahkan.
Terima kasih Bu. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Mungkin ini udah siang ya. Selamat siang. Salam sejahtera untuk kita semua. I think good morning for Professor Philip Hill from the University of not. Good morning to Professor Ronald van Crevel. I think in Europe still in the morning. And good afternoon to Professor Philip Hill from the University of Otago, New Zealand. Yang saya hormati Pak Bahti Alisabana PhD sebagai Ketua Puris dan juga pembicara kolega saya Pak Dr. Panji. Pertama saya ingin mengucapkan syukur alhamdulillah pada siang ini kita bisa berkumpul bersama-sama untuk melaksanakan suatu aktivitas akademik yang tentu saja sangat bermanfaat, khususnya bagi para katakanlah peneliti ataupun para dokter yang terkait dengan tuberkulosis. Secara khusus, saya atas nama universitas ingin menyampaikan apresiasi, mohon izin mungkin dalam bahasa Inggris ya, on behalf of the Universitas Padjadjaran, we would like to appreciate to Professor Ronald van Crevel from the University of Nieuwegein, Netherlands, and Professor Philip Hill from the University of Otago, New Zealand, will be giving a presentation or anything about the TB to our participant. Jadi, terima kasih yang sedalam-dalamnya saya atas nama universitas kepada Profesor Ronald van Crevel dan Profesor Philip Hill atas kesempatannya memberikan presentasi di acara webinar pada siang hari ini. Tentu saja ucapan yang sama kami apresiasi juga, terima kasih kepada Pak Bahti Alisabana PhD dan juga Pak Dr. Panji Hadi Sumarto. Bapak Ibu, audiens webinar pada siang ini yang berbahagia, izinkan saya menyampaikan beberapa hal yang mungkin bisa menjadi gambaran setelah saya mendapatkan informasi dari pusat riset yang dipimpin oleh Pak Bahti, PhD. Jadi kita ketahui bersama bahwa penyakit TB ini sudah ada sejak kita mengenal peradaban manusia dan tentunya sekarang masih menjadi masalah kesehatan masyarakat yang besar. Setelah pandemi, kemarin kita mengalami COVID-19 sedikitnya 2 tahun ya, dan sekarang mungkin sedikit berangsur. Kita kembali harus mengatasi permasalahan barangkali sekarang TB di dunia. Dan Indonesia adalah merupakan TB ini penyakit infeksi penyebab kematian terbanyak. Indonesia kita ketahui bersama mungkin di negara kedua ya atau negara ketiga yang memang terbanyak di dalam hal masyarakatnya menderita tuberkulosis ini. Tentu saja saya sudah mendapatkan informasi bahwa peneliti Universitas Padjadjaran ini telah berupaya meneliti TB sejak tahun 2000 dan bekerja sama dengan khususnya dengan Profesor Ronald Van Crevel dari Universitas Nieuwegein, Belanda, dan juga Universitas Indonesia. Penelitian TB dimulai dengan penelitian diagnostik yang selanjutnya dengan penelitian penyakit yang rentan kena tuberkulosis. Kemudian berlanjut ke penelitian dasar yang berkaitan atau saling kait-mengkait. Nah, kolaborator dari peneliti kita yang juga sangat berjasa adalah tadi kita sudah sama-sama sebutkan juga adalah Profesor Philip Hill dari Universitas Otago, New Zealand. Sejak sekitar 2010, beliau ini terlibat aktif mengembangkan bidang penelitian epidemiologi dan juga kesehatan masyarakat. Hingga saat ini, kelompok penelitian tuberkulosis di Universitas Pajajaran ini saya memperoleh informasi lebih dari 10 orang postdoktoral multidisiplin dari ilmu kedokteran dasar, klinis, farmakologi, mikrobiologi, dan kesehatan masyarakat, serta psikologi. Tim penelitian diakomodasikan awalnya tentu saja di pusat studi infeksi klinis, dan sejak tahun 2020 barangkali ini kita melihat kepentingannya di Universitas Pajajaran bahwa pusdi infeksi klinis ini melalui afirmasi tentunya atas kebijakan pimpinan sekarang menjadi pusat riset ya di bawah Universitas Pajajaran, khususnya di bawah kantor Warek 3. Dalam kesempatan ini kami menerima 2 kolaborator kami yang sangat kami banggakan. Kami sangat berterima kasih atas semua jasa-jasa Prof. Reynold Van Crevel dan Prof. Philip Hills yang sudah memberikan bimbingan dan sekaligus edukasi pendidikan pada tim peneliti kami. Peneliti tuberkulosis dilaksanakan di Unpad sudah sedemikian mendalam dan tentu saja sangat luas sehingga besar kemungkinan kita bisa memberikan kontribusi yang lebih banyak lagi bagi pengendalian tuberkulosis di Indonesia. Selama pandemi tentu saja pengelolaan TB ini saya mendapatkan informasi sudah mengalami sedikit penurunan barangkali, dan tentu saja banyak sarana kesehatan kita ketahui bersama tutup ataupun membatasi aktivitas selama adanya COVID-19. Dan banyak pasien yang memang mungkin sangat terlambat di dalam diagnosis dan juga terlambat mendapatkan pengobatan. Tentu ini menjadi tanggung jawab kita bersama. Hari ini kita akan sama-sama mendengarkan presentasi dari Profesor Reynold Van Crevel dan juga Profesor Philip Hill dan juga pembicara tentunya dari Universitas Pajajaran sendiri, Pak Bahti, Pak Dr. Bahti dan juga Pak Dr. Panji. Tentunya kita berharap mereka dapat memberikan pemikiran mengenai apa yang bisa dikontribusikan lebih luas dan lebih mendalam lagi oleh Universitas Pajajaran. Besar harapan kami bahwa tim katakanlah tuberkulosis Unpad ini dapat menyebarkan, menularkan ilmunya ke peserta pendidikan dan peneliti-peneliti muda yang sekarang hadir pada webinar siang ini, sehingga tentu saja luarannya ini dapat terasa pada pengentasan tuberkulosis di Indonesia. Saya kira itu yang bisa saya sampaikan. Dengan mengucapkan Bismillahirrahmanirrahim, saya buka webinar siang ini dan mudah-mudahan bermanfaat dan penuh barokah untuk kita semua. Terima kasih. Bil Taufiq Hidayah. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon.
Ya, kita berikan tepuk tangan pada Prof. Hendarmawan. Hatur nuhun atas sambutannya, Prof. Hendarmawan. Selanjutnya kita akan ke acara utama, yaitu talk show, bukan talk show ya, apa ya? Kita akan berdiskusi lebih lanjut mengenai tuberkulosis dan update-update terbaru mengenai tuberkulosis. Langsung saja saya undang ke depan moderator untuk hari ini, yaitu Dr. Ahmad Rizal Ghanim. Kita beri tepuk tangan untuk Dr. Ahmad Rizal. Ya, Dr. Ahmad Rizal Ghanim adalah dokter spesialis saraf dan staf pengajar di Departemen Neurologi Rumah Sakit Hasan Sadikin dan FK Unpad. Dr. Ghanim sudah memiliki pengalaman dan juga berkecimpung lama terkait tuberkulos meningitis, sehingga kita juga sangat honored ya Dok bisa mendapatkan Dr. Rizal sebagai moderator. Kemudian selanjutnya saya akan mengundang juga pembicara untuk hari ini, Dr. Bhakti Ali Syahbana. Enggak, silahkan ke depan Dok. Ya. Kemudian Profesor Reinoud van Krevel, please welcome to the stage. Professor van Krevel was my promoter during the PhD, so I'm also very honored to have him here. And next I welcome Professor Philip Hill. Let's give an applause for Professor Philip Hill. And last but not least, we will invite the youngest from the speaker today, Dr. Panji Hadisumarto. Yeah. Okay, so I will give the floor to Dr. Rizal as moderator.
Ya. Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang and good afternoon for Prof. Philip and Prof. Reinoud. Today we are going to have actually guest lecture from our honored professors, and also we will also have some talks from Dr. Bhakti Ali Syahbana and Dr. Panji Fortuna. So these are Prof. Reinoud van Krevel and also Professor Philip Hill. They are known scientists. One is from the Netherlands, Prof. Reinoud, and also Prof. Philip Hill is from New Zealand. So it's from it's like how many hours to Netherlands? It's like 6 hours different in the west and to the west and to the east. So we have been collaborating with them since with Professor Reinoud. We have been collaborating for more than 20 years, yeah, Prof. Reinoud, and with Prof. Hill also. It has been a long collaboration with him as well. So before we start, we will introduce the speakers today. The first speaker would be Dr. Bhakti Ali Syahbana, SPPD KPTI PhD. Beliau adalah Ketua Research Center for Care and Infectious Research in Universitas Padjadjaran. Dr. Bhakti sudah menghasilkan banyak sekali karya tulis ilmiah, baik ditulis sendiri atau bersama-sama dengan penulis lain. Angkanya 3 digit. Dan menerbitkan lebih dari ada 2 buah buku, dan juga beliau mempunyai citation index dan age index yang tinggi di Google Scholar, dan masuk dalam peneliti terproduktif ranking Sinta nomor 16. Dr. Bhakti menerima tanda penghargaan sebagai 200 peneliti terbaik Indonesia berdasarkan Science and Technology Index dari UNPAD berturut-turut pada tahun 2019 dan 2020. Peneliti berprestasi Universitas Padjadjaran bidang Saintek tahun 2020 dan seterusnya, panjang sekali nanti nggak habis-habis. Dan sudah bekerja di bidang tuberkulosis sejak mahasiswa saya kira sampai sekarang. Kemudian pembicara kedua adalah Prof. Reinoud van Grevel. Okay, it's only 5 lines. Bhakti is this much. Prof. Reinoud is an internist infectious disease specialist who combines clinical work in infectious diseases with teaching and research. In his research, he links clinical studies related to TB with genetics and other laboratory research, and also studies into the quality and accessibility of patient care. He has a special interest in resistance to Mycobacterium TB and combined tuberculosis and diabetes, and also in tuberculous meningitis. Yeah, it has to be mentioned. And Prof. Philip Hill on my right, on my left. He has many qualifications. He works as a medical practitioner and specialist public health physician, and also specialist infectious disease physician. He is a fellow of Royal Society of New Zealand and has gone through many trainings and has been working in Gambia before returning to New Zealand, I guess. And Professor Hill is the first holder of the McAuley Chair in International Health, and is founding director and co-director of the Center for International Health at the University of Otago. He is involved in research projects in Asia, Africa, Europe, and South America, and also in the Pacific. He is also a adjunct professor in the New Communicable Disease Research Center at Fiji National University. And his major collaboration in the TB research is with the TB Research Center in the Universitas Padjadjaran, Bandung. And the last speaker would be Dr. Panji Fortuna Hadi Sumarto, MPH. Currently, he is a PhD candidate of University of Otago, and also a lecturer in Faculty of Medicine, Universitas Padjadjaran. He was graduated from UNPAD in 2004 and got the Master of Public Health from Georgia State University, and go for a global health course in Harvard School of Public Health, and has been a lecturer since 2006 until now. And before that, he has been a medical research doctor at U.S. Naval Medical Research Unit. And he is a researcher at TB Working Group Universitas Padjadjaran, and he has many interests: infectious disease epidemiology, vaccination, political economy of health, and also a classic guitar player, I guess. Yeah. Yeah, okay. So it's quite long. So each speaker will have 20 minutes of a talk, and maybe you can choose whether you will stay here or back to the seat that you have. And for the first time, I'd like to invite Dr. Bhakti Alisabana to give a talk on about the TB working group of the research center in Universitas Padjadjaran, taking tuberculosis challenge in Indonesia. Dr. Bakti, the time is yours.
Thank you very much. Mohon maaf, mic-nya. 1, 2, biar pakai ini biar nggak kena. Mohon izin nggak pakai masker supaya ngomongnya lebih lancar. Ya, assalamualaikum warahmatullahi wabarakatuh lagi. Selamat siang lagi. Jadi saya dapat tugas sebenarnya menugaskan diri sendiri, berusaha memperkenalkan apa itu Research Center for Care of Control of Infectious Disease dan apa itu TB Working Group yang ada dalam kelompok kita. Jadi mungkin saya bisa dalam 15 menit kalau bisa, jangan lama-lama. Karena yang penting adalah tamu kita bisa memberikan kuliahnya. Could you please Astri tolong share slide. Excuse me Renaud and Philip, I use bahasa. It's much more communicative. Okay. Ya, jadi RC3ID Unpad itu adalah Research Center for Care and Control of Infectious Disease. Slide selanjutnya. Jadi seperti kita ketahui dia ada di bawah DRPMI atau di bawah Warek 3. Next slide. Ya, jadi visi dari kami adalah agak susah untuk lihat baca di sini, saya harus maju dikit. Yaitu kita berusaha menguasai pengetahuan, jadi dengan penguasaan atas pengetahuan kita bisa berkontribusi lebih besar dalam pengendalian TB. Dan misi kita adalah mengembangkan upaya inovatif dan efektif dan berupaya memeratakan layanan pengelolaan dan pengendalian. Slide selanjutnya. Tolong Mbak Astri supaya cepat ini, supaya kita bisa cepat selesai. Ya, jadi riwayat perkembangannya itu 2006 kita dulu dalam unit penelitian kesehatan, saat itu kita adalah TB Working Group, lalu masuk HIV dalam Impact prior sama Dr. Rudi. Lalu 2011 kita masuk menjadi pusat studi TB HIV. Lalu kita digabung lagi di konglomerasi atau disatukan menjadi pusat studi infeksi klinis. Lalu 2020 kita menjadi pusat riset RC3ID yang di dalamnya adalah semua yang ada di pusat studi infeksi klinis yang tadi sebelumnya. Next slide. Ya. Jadi apa yang konsep yang kita berlakukan yaitu adalah suatu penelitian itu bisa menghasilkan policy atau strategi yang bisa memperbaiki pelayanan. Dan dari pelayanan itu pasti akan ada gap baru lagi yang menjadi research problem untuk penelitian selanjutnya. Dan dalam lingkaran itu kita bisa ikut sebagai peneliti S2, S3 atau sekedar mengambil skripsi, tapi kita juga memberikan masukan kepada pemerintah dalam bentuk policy change dan strategi. Next slide. Ya. Apa fungsi daripada RC3ID? RC3ID itu bukan departemen yang secara struktur ada di bawah Unpad atau RSAS, tetapi RC3ID itu lebih fungsional. Jadi memfasilitasi pelaksanaan penelitian dan pengembangan, koordinasi antara peneliti, proyek, dan unit kerja, membina kerjasama, memfasilitasi pengembangan ide dan inovasi, dan aktif mendorong pemanfaatan dan diseminasi hasil penelitian. Jadi penelitinya dari mana aja boleh. Slide selanjutnya. Ya, kalau dilihat dari 6 building blocks dari WHO, maka RC3ID itu, mohon maaf itu kalau nggak salah mic-nya. Terus, ya, jadi dari 6 building blocks itu kita menyadari bahwa yang satu itu kesehatan kayaknya kita nggak bisa ngatasin itu masalah manajemen banget. Yang selanjutnya adalah 1, 2, 3, 4, 5 itu adalah dari sistem informasi, metode screening diagnostik, metode pengobatan, pencegahan efektif, dan penyampaian layanan kesehatan. Itu adalah bidang kerja kita yang sampai saat ini rasanya disetujui oleh teman-teman, belum ada yang protes. Next slide. Roadmap, kalau kita bikin roadmap, biasanya panjang, kompleks, dan sebagainya, tapi kita berusaha bikin roadmap untuk semua. Jadi prinsipnya kita mau kerja penelitian di bidang apa? Di bidang pencegahan, di bidang diagnosis, nanti semuanya itu akan masuk ke dalam bagaimana kita menyampaikannya, bagaimana kita mengupscale service yang kita berikan atau strategi baru yang kita ingin sampaikan. Next slide. Dan working group kita ada 5, yaitu tuberculosis, HIV, acute respiratory infection, dengue, dan sepsis dan antimicrobial stewardship. Slide selanjutnya. Ya, kalau dilihat dari kelompoknya, sebagian ada di sini teman-teman, memang paling besar adalah kelompok tuberkulosis. Lalu ARI itu yang mungkin nomor 3, yang kedua besar adalah HIV, yang ketiga adalah ARI, yang keempat adalah dengue, dan yang sepsis itu adalah yang lagi kita kembangkan. Hanya sayangnya memang orang-orang yang kerja di tuberkulosis juga kerja di dengue, orang yang juga kerja di sepsis, jadi saling tumpang tindih, jadi kita benar-benar masih membutuhkan banyak sekali peneliti-peneliti muda. Slide selanjutnya. Ya, ini hanya menunjukkan bahwa kita multidisiplin, jadi ada farmakologi, kesehatan masyarakat, dan sebagainya. Ya. Jadi karena itu kita bersyukur sekali dari UNPAD mau mengadop kita menjadi pusat riset. Selanjutnya, bagaimana capaian aktivitas? Mungkin aktivitas publikasi kita lihat 2018 lebih tinggi ya, yang kuning itu. Tetapi tahun 2022 kita baru setengah tahun berjalan. Aktivitas proyek kita lihat bahwa 2022 kok bisa mencuat ya. Mungkin karena semakin besar kebutuhan akan penelitian dan kita berharap itu akan makin besar juga. Jadi kesempatan untuk penelitian itu besar. Next slide. Ya, kalau dilihat dari publikasi, mungkin itu tadi publikasi yang terkait tuberkulosis, tetapi publikasi keseluruhan lebih banyak lagi dan memang tetap tuberkulosis yang tim working group tuberkulosis adalah yang paling besar. Slide selanjutnya. Ya, bagaimana bisnis modelnya? Ini bisnis model biasa dibikin untuk suatu perusahaan. Saya coba bikin untuk Pusris. Di dalam suatu bisnis model itu ada kita mau dapat dana dari mana, apa yang kita bisa berikan dan sebagainya ya. Ini silakan dibaca. Tetapi yang paling penting, next click, bahwa value kita adalah kita harus melakukan pekerjaan sampai selesai, lalu efektif, inovatif, kita menghargai orang lain dan menghargai kolaborasi dan tumbuh dan berkembang. Slide selanjutnya. Ya, mengenai TB Working Group, list ini masih kurang panjang, jadi mungkin satu-satu saya menjelaskan tentang TB Working Group dan kelompok-kelompok kerjanya. Hanya mungkin mohon maaf kalau ada nama yang tidak tersebut, tetapi prinsipnya kami sampaikan di sini adalah supaya peneliti-peneliti muda bisa berhubungan dengan kami, hubungan sama siapa aja, tertarik sama siapa, silahkan hubungi mereka yang berpengalaman dalam bidangnya. Next slide. Ya, awal adalah penelitian diagnostik. Waktu itu saya dibimbing oleh Prof. Renot, bekerja di Jakarta, meneliti sesuatu yang sangat sederhana, yaitu bagaimana meningkatkan diagnostik dari sputum mikroskopi. Ya. Lalu kemudian sampai sekarang, Dr. Alit dan kawan-kawan meneliti yang lebih canggih sampai computer digital imaging reading. Next slide. Next. Kemudian Dr. Ida Parwati dan Dr. Lydia membuat penelitian tentang macam-macam ya, dari selain acid fast bacilli juga auramin, fluorescent microscopy, lalu culture liquid, dan PCR. Sebelum adanya Gene Expert dan atau yang kita sebut TCM. Dan dari penelitian ini menghasilkan kita bisa memetakan strain typing dari pasien-pasien yang kita kelola. Next slide. Kita pada saat itu juga langsung bergerak dalam bidang penelitian tuberkulosis dan diabetes. Ini adalah penelitian TB comorbidity yang paling besar mungkin di samping TB HIV, di mana track record kita cukup banyak dan di bawah adalah peneliti-peneliti yang terlibat dalam TB diabetes dari sejak tahun 2004 sampai sekarang, dan sekarang masih sangat produktif kelompok ini. Next slide. Ini adalah kelompok TB Immunology. Ini kelompok yang dari dulu juga sudah mulai, tetapi memang belum solid sehingga mempunyai proyek sendiri. Di sini ada Dr. Ediana, ada Marin Rutherford, ada dan yang ada dua yang baru, yaitu Dr. Lani dari rheumatologi dan Dr. Intan yang baru kembali dari Belanda. Kita berharap bisa membesarkan kelompok imunologi. Slide selanjutnya. kelompok imunologi ini juga dibantu oleh Ayesha dari Otago yang meneliti mengenai latent TB infection dan apa faktor-faktor apa yang menyebabkan seorang bisa latent TB dan bisa mencegah dirinya menjadi latent TB. Ya, jadi bukan hanya mencegah jadi TB, tapi mencegah menjadi latent TB. Dan dengan penelitian yang cukup canggih dan multidisiplin juga, dengan melibatkan microbiology dan imunologi sekaligus, kita bisa menghasilkan, terima kasih. Lanjut, next slide, next click. Ya, kita bisa menghasilkan satu data yang sangat sulit diperoleh sebenarnya, yaitu seberapa besar BCG itu bisa mencegah latent TB infection. Oke, next slide. Kemudian latent TB prophylaxis di sini dipimpin oleh Prof. Nina dan Lika Apriani, bekerja sama dengan Dick Menzies dari Kanada, dan mereka dari penelitian ini berhasil juga mengedepankan strategi pemberian rifampicin untuk latent TB prophylaxis. Dan saat ini sudah masuk ke dalam program TB nasional. Next slide. Dengan penelitian-penelitian yang banyak itu, maka kelompok kami bisa memetakan prevalensi dari latent TB di kelompok-kelompok yang sangat high risk ini. Dan ternyata prison dan healthcare worker itu adalah kelompok yang paling berisiko untuk latent TB. Tetapi kita melihat bahwa kejadian TB-nya ternyata prison lebih rendah sedikit dari healthcare worker. Tapi tentunya ini penelitian bukan dilakukan bersama-sama, jadi mungkin angka-angkanya tidak benar-benar perlu bisa dibandingkan. Tetapi secara umum kita bisa lihat bahwa latent TB pada diabetes dan HIV kelihatan kecil, tetapi bisa lihat kejadiannya tinggi. Berarti kemungkinan diagnostiknya di sini memang kurang bagus untuk menentukan latent TB pada HIV dan diabetes karena imunologi mereka yang tidak baik. Dan kejadian TB mereka jauh lebih besar karena mereka imunologi mereka tidak baik juga. Jadi ini adalah hasil dari berbagai penelitian yang dilakukan oleh teman-teman kami. Next slide. Lalu penelitian whole genome sequencing ini juga sebelum Pak Menkes sibuk dengan whole genome sequencing, kita sudah melakukannya dari lebih dari 5 tahun yang lalu, dan ini kita bisa melakukannya untuk strain typing, untuk detection dari clustering dan transmission, drug sensitivity testing, dan pathophysiological study seperti ini. Ini adalah whole genome sequencing dari pasien-pasien TB meningitis. Dan ini dipimpin oleh Dr. Lydia dan Caroline Rusen dari Belanda. Next slide. Ya, Prof. Nina dan Rizal membuat satu paper yang juga fenomenal masuk ke dalam Lancet. Ini adalah bagaimana efek daripada rifampicin high dose untuk TB meningitis. Walaupun itu pasien yang diambil hanya sekitar 30, ternyata sudah menghasilkan penurunan mortalitas lebih daripada sekitar 50%. Jadi saat ini sedang dilakukan penelitian yang lebih besar dengan fase 3 kalau nggak salah. Next slide. Ya, TB meningitis ini kelompok yang besar. Kalau saya ceritakan nggak selesai-selesai. Nanti biar kapan-kapan Dr. Rizal yang menjelaskan. Tapi ini semua teman-teman yang bergerak dibilang TB meningitis. Next slide. Lalu multi drug resistant. Di sini juga teman-teman dari pulmonologi. Di sini ada Dr. Prayudi dan Dr. Boni dan Dr. Basti yang sibuk mengumpulkan kelompok MDR TB, dan ini adalah suatu tempat penelitian yang juga sangat penting, dan prevalensi MDR TB itu meningkat terus. Next slide. Next. Lalu di sini akan lebih banyak diceritakan Dokter. Halo. Nanti ini akan lebih banyak diceritakan oleh Dr. Panji, tapi prinsipnya kami melakukan banyak penelitian dalam public and private mix. Next slide. Lalu kembali dengan segala keaktifan kita dan pengalaman kita mulai masuk ke dalam active case finding dengan melibatkan semua diagnostik yang kita punya, yaitu chest X-ray, sputum microscopy, TCM, culture, dan sebagainya, dan juga sebentar lagi latent TB kita akan mulai diimplementasikan ke dalam satu paket active case finding. Next slide. TB vaksin ini juga masih dalam project yang masih dalam pembicaraan. Insya Allah kita bisa mulai dalam tahun ini. Next slide. Ya, saya rasa itu aja dari kami. Jadi secara kesimpulan, RC3ID itu adalah suatu organ yang fungsional. Kita berusaha membantu staf Unpad dan juga peneliti semua yang tertarik pada masalah penyakit infeksi Jadi bukan hanya untuk Unpad saja, tetapi juga peneliti yang dari luar atau calon S2, S3 yang sebagainya ingin ikut dalam penelitian kami. Kami membantu dalam manajemen, desain, metodologi, teknologi, menyiapkan data, sampel, dan analisis. Dan pendekatan yang kita lakukan itu juga bukan hanya untuk tuberkulosis, tapi juga untuk penyakit infeksi yang lain, bahkan juga untuk penyakit non-infeksi. Itu saja dari kami, terima kasih. Selesai slide terakhir. Ya, ini adalah pihak-pihak yang banyak membantu kami, di samping Prof. Reynolds, Van Krevel, dan Filipil. Kita juga banyak dibantu oleh Dinas Kesehatan, terutama Dinas Kesehatan Kota Bandung. Thank you very much. I hope it's quite clear. Thank you, Rizal.
Thank you very much. Terima kasih, Dr. Bakti. And next we invite Prof. Reynolds Van Krevel to give an insight about what would it take to improve TB control, exciting new development in TB treatment, vaccine, and management of clinical TB. Reynolds, the time is yours.
It was a bit of a long time. This satu. Well, thank you very much for the introduction. It's great to be in Bandung after 2.5 years because of COVID. So I thought I'll start with a little bit of COVID and a little bit of TB, but first TB, next slide. So we've been distracted by COVID, but can you give the next slide? Oh, sorry, I missed what you were showing. No, yes. So, sorry. So worldwide, a lot of TB patients, the highest incidence rates maybe in sub-Saharan Africa, that's because of HIV, but the largest numbers of patients in Asia. But for me, working as a doctor in Europe, also Europe is not free from TB. Next. So this was a patient recently admitted, also showing the social determinants of disease. This is a migrant worker who comes to cut our cows and make sure that we can eat meat. And this poor man had a terrible TB that even had a fistula from the lungs to the skin. And this was MDR TB, and he had a neglected HIV infection and hepatitis C infection because he was injecting drugs. And so next slide. And this man was from Lithuania, and the largest numbers of TB patients in Europe come from Eastern Europe, and actually next, the largest numbers also with HIV and with MDR TB come from Ukraine and Russia. And the war is never good for TB, so we'll see massive numbers of TB spreading from Ukraine, I'm afraid, because clearly their priority is not now to make sure that people take the medication for 9 months or longer with an MDR TB. Next. Next. Okay, and so sadly last year with the COVID, for the first time in many years, mortality due to TB went up. And this was for the first time actually. And the next, there's a number of reasons. So here you see the global trend of TB notifications on the left upper panel. But you see it's rather different in different countries. So for instance, in Indonesia, you see an enormous drop in the monthly number of notified cases. While in Uganda, it was only taken not every month, but every 3 months. You see that there was a dip, but then the notifications reasonably rapid soon we're up again. Next. And also you see that the TB deaths in Indonesia, the projected number of TB deaths for the coming years are projected to remain elevated for quite some time, while in Uganda they are going down more quickly. And also the TB incidence in Indonesia, unfortunately, due to COVID for the coming years, is expected to be up. Next. So why? Well, there's many factors. So COVID, of course, it disrupted medical services. Doctors couldn't, nurses couldn't go to work, and patients couldn't go to hospital. Patients were maybe afraid. Health staff got ill. Machines, experts had to be used for COVID instead of for TB. So there were a lot of interruptions in the services, and this all led to fewer cases being diagnosed, more transmission, more people dropping out of treatment, more infection, more spread. So on every angle, let's say, this had bad effects on the TB pandemic. Next. And also, to continue a sad story, if you look at funding, if you see, well, that's TB, it should be, and it's, you see here compared to COVID, this is COVID vaccines, this is all COVID, and it's 100 times more funding in 2020. Next. And if you look at vaccination, so we have a TB vaccine since when was BCG? Yes, BCG was licensed in 100 years ago, actually. And we've been working on newer vaccines, but you see it goes slowly, slowly. While for COVID, we had 25 licensed vaccines within a year. And the funding does help. So if this amount of funding would be spent on TB, I'm sure we would be doing a better job. Next. And also, yeah, next, let's skip this one. And it's not just global. This wonderful TB group here in Bandung is also studying some of these issues. So one of the main issues in TB is also that there's a lot of people who are sort of moving around, but they're not diagnosed, and they may transmit disease to others. And so Boni, Lestari, and others, they looked at the pathways of patients, and they followed 400 patients here in Bandung, and it takes them, and these are the ones who reach the final destination. They get a diagnosis. So we don't know about the ones that get lost on the way, but the ones that are successful in reaching a diagnosis, it takes them a median 7 visits to health practitioners, and often it's different health. So they start in a place where you can't get a TB diagnosis, a drugstore, or some kind of private doctor in the community who doesn't have a gene expert, who doesn't have the means to diagnose TB, and only slowly they are being diagnosed. Now, this is exemplary for what happens in many countries. If you look at India, they have a massive number of people who sort of don't reach a diagnosis and who keep on transmitting disease and who may get more ill themselves. Next. And also, disease comes at a very high cost. So catastrophic cost is now something being reported in the global TB report. And you see the proportion of people suffering from catastrophic costs, and it's about 50%. And if you have drug-resistant TB, it's even much higher. So families that have someone with TB really suffer enormously. Indonesia, I think, is here. Yeah. So next. And then when you think you're done, you've been treated for TB, you think you're cured, then there's many patients who suffer from post-TB. And so Indran Dewi, our MC today, is hoping to study this post-TB, so the sequelae of TB. Next. So there's many patients who after TB have structural lung damage that make them susceptible to other infections, but they also suffer more cardiovascular disease, more cancer, and as a result, the mortality is about 3-fold higher than people who didn't have that history of TB. So even beyond the TB, there are enormous health problems associated with TB. Next. Well, this is becoming a very sad story, but now there's some good news, because in recent years, there's really been some very important new findings, and I think we're in a very exciting time on all fronts in TB. There's a lot of good news. Next. For instance, for the first time in 100 years, we have a vaccine that shows efficacy against TB in adults. The old BCG vaccine protects young infants against, especially against disseminated disease, but it doesn't protect adults. But now there is a new candidate that showed where a study in South Africa. So, and these were people who were already infected, because most, as you know, TB is a two-stage disease. You get infected. One of the world population is infected, latently infected, no symptoms. They don't transmit disease to others. But one day the disease, with HIV, with diabetes, with immunosuppressive drugs, with older age, the disease may become active. So in South Africa, most adults will be latently infected, IGRA positive. So they included more than 3,000 of those latently infected individuals, vaccinated them, and corresponding with some nice immunological readouts, there was a 50% reduction in the number of these adults that developed active TB. Very exciting. Next, there's also nice diagnostic developments. Well, you are now wearing face masks, but face masks have been used in a new diagnostic development in TB. Breathing into a face mask can help you make the diagnosis. So you can imagine you're waiting for the doctor, you get a face mask before you enter the office of the doctor. The face mask is used for a molecular test, and immediately the TB can be shown. And it actually shows that without coughing, we already breathe TB. And there is other new sort of sputum markers that we can use during treatment. We hope to evaluate one of those sputum markers here in Bandung with Lydia Kaidia. And simple immunoassay, within 1 hour, you get a result that is as good as a 2-month culture. Very exciting. Whole genome sequencing, next, has brought us a lot of information on drug resistance. And for the first time, the WHO has produced a catalog of drug resistance mutations based on whole genome sequencing. And the largest evidence base is for rifampicin and isoniazid and ethambutol, where the sensitivity is really good. We need to improve. You can't read it here, but here's bedecaline, one of the most promising drugs. And our genetic testing is not good enough yet for bedecaline. But this shows that with genotypic testing, instead of the old-fashioned, very long phenotypic testing, we can get very reliable results for drug resistance testing. Next. And here in Bandung, Lydia and a colleague from the Netherlands, Caroline Russe, they showed that you can also link this genetic testing to the minimal inhibitory concentration. Next. And this could help you to say, well, this is a patient where the bacterium is still susceptible to the drug as long as we give it in a high dose. And this is a patient where the drug is not going to work. Next. Bhakti already alluded to it, artificial intelligence. So an automatic X-ray reading that within 1 minute gives you a probability that a person has TB. Next. And that can help you triage patients that you follow up for sputum tests. Now, I won't go into the details, but just to tell you that the algorithm is, I'm sorry for the radiologist, but overall it's more reliable than the radiologist. And it's more quick than the radiologist, because this can be performed in a place where you have no radiologist. And these algorithms only get better with more images in the algorithms. Next. And this is very important, because if we want to control TB, there's a lot of patients who may have subclinical TB. They're not visiting a doctor because they don't have a cough. But if you make an X-ray, you will see lesions, and you can find TB in those patients. 50% across the studies around the world, 50% of TB is estimated to be subclinical. So we don't easily see it. And if we only look for symptoms, we won't find these individuals. So we need a tool like X-rays. And also, besides the X-rays, we are now using blood transcriptomics. So you look at the gene transcription or other tools. They will come to the market in the coming years that can help identify individuals with subclinical or early disease. which may also be easier to treat. Maybe we can treat those individuals in 1 month or 2 months because they only have very minimal disease. Next. And then when treatment, there's a whole range of new drugs on the market. There's a whole drug portfolio, and there's large global trial platforms that are testing these drugs across the world in clinical trials. Next. And so this has led, for instance, for MDR and for XDR, that there's a 6-month regimen that seems to be very effective, and that by 4 weeks already 50% of those MDR, XDR patients are already culture negative. And you see a beautiful outcome after 6 months. And here, this is after a comparison of a drug regimen without the injectable for drug-resistant TB versus the old-fashioned injectable regimen. More effective and obviously much better for the patient. Next. Also very exciting, not just antibiotics. For the first time, a trial that showed that host-directed therapy, so if we somehow stimulate the immune system or modulate the immune system, that can have a positive outcome. Here the endpoint was lung function. Well, remember though, the post-TB, this is very relevant. Young people who get lung TB, they age very quickly. They develop bronchiectasis and emphysema, etc. If we can reduce that with host-directed therapy, we will give them a benefit for the rest of their lives. And so for the first time with host-directed therapy in a randomized trial, there was a clear benefit on pulmonary function. Next. So these are just some examples. And if you think about, and they're very different, if you think about tools we can use to improve TB control, maybe we start with the natural sequence. So you're exposed to the bacterium, you get infected, asymptomatic latent infection, which may develop into active TB disease, which you can transmit to others, and that active TB can either be cured or it can lead to failure, treatment failure, or death. And there is the post-TB and recurrent TB. And in this cycle, next, you can try either to reduce the risk of TB or to improve the outcome. Next. And you can keep on clicking. So there's infection prevention, face masks. There's vaccination, the new developments of vaccination next. There is screening for latent TB and preventive therapy. Philip will speak about that. There is early case finding like those X-rays or blood tools. Next. There is, of course, we need to identify our patients, treat them well, look at resistance, provide them adequate regimens, etc. Yes, next. Maybe host-directed therapy, next. Looking at comorbidities and supportive care, next. Maybe we should follow up patients next beyond TB treatment. And then, of course, there's factors that are relevant for all of these events next, like smoking, next, like HIV, like diabetes, like nutrition, and social determinants, poverty. So there's not a single bullet. And I think your group is a beautiful example next of how you can address many of these issues in research, because besides the science, you also need to move things and implement the science. We can generate the evidence, but we also need to make sure that it's implemented. So that's another challenge. Here you see it for the cascade of care for TB preventive therapy. There's a lot we need to do to move from evidence to practice. Or from policy to practice. Next. Okay, so TB is a very important pandemic, and COVID has set things back, but COVID has also taught us lessons which we can use in TB, how we can speed up things. And these are exciting times. Many exciting developments on all fields in TB will help us. And if we can move the evidence to policy and the policy to practice, I think we will be able to control better the TB much better. Now, just very briefly, I want to relate this to your group. Bhakti has already mentioned it. Yes, next. This started many years ago with Prof. Ida and Prof. Nina and Bhakti, sort of the very simple pohon penelitian of TB patients next. And this developed into large projects. Just an example, TB and diabetes, based on the work in Indonesia, we could lead and involve colleagues in Peru and South Africa and Romania. Next. And this led to changing guidelines. So here's Alit, who's hopefully will defend her PhD on this topic by the end of this year, based on beautiful clinical epidemiological studies next, with very sort of practical clinical guidance for clinicians. Next. Next. And this also led to a large project in Africa. And they know you better than you know them. But people in Uganda and Tanzania know Bandung for the work on TB diabetes. Next. TB meningitis is another beautiful example. Group science, 4 people who did a beautiful PhD on TB meningitis, work on drugs, work on diagnostics, work on immunology and metabolomics and genetics, beautifully published. Next. And it's ongoing. Next. And so this is a slide from Dian, which shows a beautiful large team and Rizal in the middle. That's good. Leading a large effort on TB meningitis. Next. And let's skip this one. Next. 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 Another example is infection. Philip will speak about infection. Well, right now in the Netherlands, Todia Setiabudi, when he's in Nijmegen, he's doing all kind of very complex things with metabolomics and genetics, trying to understand why some people who's, let's say, they share a bed with someone who's 3+ positive TB and coughing TB all the time, but still the partner doesn't get infected. They must have super macrophages or a super immune system, and we are trying to find out how that works. Next. Now I could go on for this, but it's just to show you, and this is not all that is done here, but really I think you have good questions, you have good science, you have good values, good and very good professionals, and with the collaboration, I really think you can help generate the evidence to help control TB in Indonesia, but also elsewhere. Next. And there's a lot of people, of course, who contribute to this, and there should be many more on this slide. And I also want to say there's always room for talent. So if there's young people who have completed a master or have completed a PhD or are keen on something, whether they're in the lab or whether they're in public health or whether they're clinical or genetic, come to us, speak to us, and we can see if there's opportunities. Many of the researchers who now did a PhD, they started as a field physician or they started as some kind of research assistant, and they grew into the team, and they ended up with a beautiful scientific career, let's say. Okay, with that, I'd like to thank you and give the word back to the moderator.
Thank you very much, Reynold. Yeah. Next, we will have some more insight from Professor Philip Hill from Otago, New Zealand, that will speak about active case finding, inclusive TB infection management, a complete package needed for Indonesia. The time is yours. Thank you.
Thank you, everybody. Thank you, Prof. Hendramawan, Deputy Rector, Dr. Bhakti. I think we were working here. Oh, okay. So thank you very much. I'm from New Zealand. from the University of Otago. We've been working with Dr. Bhakti and the rest of the TB research group for the last 14 years and collaborating with Prof. Reinout and others in a wonderful collaboration. And as Reinout said, we have Bandung is world famous in TB research now. I think that it's when you travel, you will find this out. And some of the major findings from here in Bandung are influencing things around the world. So it's very exciting, and we can all be very proud of the collaborative work that has been done. I think my talk is disappearing, so I think we finished. Have I got? Thank you very much. So I do a lot of blue sky research, as you can see. All right, I think as Prof. Reinout has explained and others, when you get exposed to a TB case, you can actually not get infected at all sometimes, maybe 10 or 20% of people. We call that early clearance or resistance to infection. For those who become infected, there's a complicated process that goes on between the immune system and the mycobacterium. Some people over the next few weeks or months will develop tuberculosis disease. The majority will either who haven't cleared the infection will contain the infection, and they will be in a constant engagement with the mycobacterium, the immune system and the mycobacterium. So if you become compromised in your immune response, then the mycobacterium will start to replicate and have an effect and may cause disease. And we call this reactivation disease or post-primary disease. And then most people actually don't develop disease at all. They'll stay lifelong, either having slowly cleared the mycobacterium or otherwise it just sits there doing nothing much. And then people can get re-exposed and go through this process again, and they may develop disease from a new exposure as well. So next slide, please. So one of the crucial things to realize is that we have opportunity to intervene before people develop disease, and that's actually very important, and this is why. So this is on the y-axis here are the new cases per million estimated in 2050. This number here, if we had it down to 1 per million, TB would be expected to go away by itself. It can't sustain itself at that low level. If we were to intervene with TB disease, improving TB disease control, with the Zoom? I won't stop? Yeah. Okay. I will stop again. Maybe we can go back to the blue sky research slide. I think that's all right. Yep. Okay. So if we were to intervene just against disease and we diagnose every case, they're all successfully treated, then we can only actually reduce the incidence down to 10 per million. If we were to forget about disease and just treat people with, diagnose and treat people with latent infection, we can only get that down to about 100 per million. However, if we treat disease and infection at the same time, we get what we call a synergistic effect from the modeling. It suggests that 1 + 1 = more than 2. So you can have a double effect. I don't know if it's double, but a multiplier synergistic effect if we do the two at the same time. And that's crucial to TB control and elimination. There are complications, and as Reinout said before, one of them is subclinical disease. We cannot treat that the same as latent infection, although we may be able to treat it less aggressively than full-blown disease. Next slide, please. Oh, what? Okay, so the question is, I'd like to look at today is, can we expand latent infection treatment? So if we go to the next slide, just one. So we have two groups of people already that we do latent infection treatment for. One, household contacts, and there is mandatory policy in children, as you know, and it's expanding into older age groups now. And the second is HIV positive. So the problem is that these are actually small groups of people when compared with the whole population. So when you actually intervene in the household of a TB case or the HIV positives, you are actually not, you're dealing with a high risk but small population. So we have to somehow impact the wider population. And next slide, please. So one option to do that is by finding other high-risk groups. So we get multiple high-risk groups across the population. Or the other approach is to forget about the high-risk group strategy and go and try and give everybody a diagnosis of latent infection and then treatment. But that's logistically very difficult. So we've been looking at maybe, let's look at if we can expand the high-risk groups. So next slide, please. So one of the questions is, can we follow TB cases back to their neighborhoods? And will their shared risk factors, socioeconomic risk factors, which we know are important for TB, because they live nearby, will that help identify a high-risk population that we can intervene? So we just go down the street and investigate the neighborhoods of the TB cases. And this is a study that was led from the group here with volunteer, do I pronounce this right? Carders, is that the right? Oh, good. I won't try and say Kampong again, I always get that one wrong. And they were actively engaged, and this engagement of volunteer networks and every part of the health system is crucial. So next slide, please. So I won't go through these flow diagrams, but at the top you can see we did recruitment in the general community. So TB households and TB neighborhoods. And just we recruited different numbers of people. But just in the households and the neighborhoods from this feasibility study, we were able to estimate with very wide confidence that probably neighborhoods are worth looking at further. But still, even with very low prevalence, we had a lot of cases in the general community, showing the main point before. If you can't access where all the cases are, then high risk groups is problematic because of the smaller numbers of cases that you can identify and latent infection that you can treat. So next slide, please. So we've expanded this to the ACF study, which is working in the household contacts and neighborhood contacts of the TB households. And we've now recruited 335 and over 1,700 neighborhood contacts. And so we're able to already start to estimate the prevalence of cases in these two different groups. And you can see that we have a 3.3% prevalence in household contacts, 1.1% prevalence in neighborhood contacts. And you will remember from the previous slide maybe that the prevalence in the general community in Indonesia is probably about half to a third of this 1.1. This is 1,100 per 100,000. So next slide, please. So we think that neighborhoods of TB cases are not as high risk as household contacts, but much higher than the general community. And we think this is quite worthwhile taking further. So diabetes is the other one. And Reinhard has spoken a little bit about this to identify another high risk group. So if we could take this further, next slide, please. So this is the tandem study again. Next slide, please. This is, so we were looking at diabetes participants and their TB and interferon gamma release assay status in the tandem study. So we managed to classify people. And then we were able to do IGRA testing on all of them and split them into different groups according to whether they were disease-free or not TB disease-free. And for this group was our particular group of interest here, to look at the positivity of IGRA test results. And then next slide, please. Then we did a comparison with TB case contacts. So we know case contacts are an important group. So if we compare favorably with them with respect to investigation, then we think that they would also then be a interesting and a high risk group. So we did an age-matched comparison within the age range of 25 to 54 years, and with diabetes patients and TB case contacts. And we found that in DM diabetes patients, there was almost 40% IGRA positivity. And in the contacts, there was almost 70%. And then we looked at active disease in each group, and it was 4.9% in the diabetes group and 1.2% in contacts. So in other words, you've got lower numbers of individuals with IGRA positivity and higher numbers with TB disease, which means for every, which means you have to treat less to reduce more TB. So it's actually a better group than household contacts. And we looked at the history going backwards, their self-reported history of having TB or not in the past, which was similar, suggesting that this difference here was probably a little bit overstated. But even if it was the same, this smaller percentage means you have to treat fewer people. So we've identified another high-risk group, and this has led to as Reinhard described, the PROTED study in Africa, and we would love to do the PROTED study in Indonesia and other parts of Asia as well, but we haven't managed to get funding for that yet. Next study. So I suppose another question, considering that we are starting to expand our high-risk group understanding, is, and we also would love, I suppose, at some stage in the future, to go more wide to the general community if we had easier diagnostic and fast and shorter treatment, which we'll come back to in a minute. But do we have the systems in place to be able to expand? Are we even doing things well now for the case contacts, for example? So we did a study on this. Can we have the next slide? So back in 2010 or so, we know that they were under 5. If you were under 5-year-old in contact with a TB case, you're supposed to have preventive treatment after being cleared of having TB disease. So we followed about 400 child contacts, and we looked for what percentage were coming back to the clinic for screening. And we only had 34 out of 403 were actually coming back. We went to other places to see if they went to another Piscesmas, for example, and we found 130. We were able to track and find out what happened to them. And yes, some of them did come back to their local Piscesmas, but it's, again, the vast majority were not getting into the system. There was a policy practice gap. So then we looked at working out how can we find a way to close this gap? So next slide, please. So we introduced this public health framework, a health needs assessment model, where you develop a situational analysis, which I'll show you in a minute. And this is comparing, looking at the current practice. And then we look at the gaps between current practice and the ideal practice that we hope to have operational. And then we develop options for closing the different gaps that we find. And then we implement a new plan for service. And we then monitor the evaluation using performance indicators, monitor and evaluate using performance indicators again. So can we, next slide, please? So this is an example of different components of the child case contact management system, different performance indicators that we came up with, and the performance target that we would like that indicator to perform at, the participants that we use to study this performance indicator, and the observed performance and the gap. So you can see for multiple components of the case contact management system in child case contact management, there are large gaps in performance. Now, I'm going to tell you something very special now. This study was done by Merrin Rutherford, and you may have heard that New Zealand has been very successful with respect to containing COVID-19. We now have it running freely in our society, but it's still not overwhelmed our ICUs. So in March 2020, we found that Taiwan, Vietnam, China, obviously, were containing COVID-19. It's not supposed to happen to a pandemic virus. So some of us wrote to the government and said, I don't think we need to let this virus get out of control in a place like New Zealand. We're away from everybody, we have a border, all those sorts of things. And then we worked out that there was an issue that the virus has a long incubation period, at least the Wuhan strain, and it's about 5 days. And that made me think, I'm a case contact person, I've studied it in Indonesia, we developed these models. 5 days, that's quite a long time. We could isolate or quarantine the contacts before of a case, before they have a chance, before they develop disease themselves, if we're fast. So we actually told the government about what we'd been doing in Bandung. That we had, and you remember Aisha Beryl, she was, through this, she actually ended up being a government minister. But this was because of work in Bandung that we introduced indicator performance to the case contact management of COVID in New Zealand. So we thank you for being part of the New Zealand success story. And we hope that we can continue to engage and give back from that special connection that we have. And this also was used by the WHO in giving global guidance to case contact management performance indicators for COVID-19. You can read the WHO guidance. It may not reference us, but we were involved in talking to them and helping them develop that guidance. So next slide, please. So this is not a problem that we saw in Bandung. This is not a problem just for Indonesia. It's a global problem. The engagement of people with latent infection who are supposed to be managed and given treatment, they are not engaging in the system. And when the system engages them, they drop off. They don't start treatment. The system doesn't take them seriously, and they don't complete treatment. So something around 10–20% of individuals around the world who are supposed to be managed properly for latent infection are not being managed. And again, this was inspired by the work in Bandung, I think, and then multiple other countries linking with Dick Menzies' group, who's been leading latent infection studies around the world for a long time. So Bandung now has a great connection with the Menzies group in McGill. Next one, please. So Reinhard showed this study. So we talked about we don't have the systems running properly to expand in latent infection. And we also have a problem that we do not have a fast, readily available, cheap point of care diagnostic test that works early in disease. And so we have this problem where if we look at wherever you are diagnosed, public sector, private sector, hospital, private practitioner, community health center, when you find these patients diagnosed there, they all have this story that they had about 6 or 7 visits to some health provider before they got a diagnosis. If we were able to have available all over the city a high quality point of care test at visit 1, completely transformed the management of TB in Bandung. Next slide, please. So inspired by the COVID-19 experience, I'd like to look maybe just a little bit into the future. So when I've been involved a little bit in helping the New Zealand contact tracing system in COVID develop optimized ways of operating. And they have worked with technology, a bit like what you have seen. I see on you've got your QR code, you have your, I can't pronounce the name, but your app, your Bluetooth, you have those tools. And we haven't applied them very well in New Zealand. We've relied very much on a little bit of this, but a lot of in the field, rapid engagement of households. But we're not doing this very much for TB control, are we? So there's a huge potential for bringing in digital technologies into case contact management in Indonesia. And I see how easily you adopt digital technology. You are in a very strong position to introduce these to TB control and lead the world in this area. Observation of cases and where they live in relation to each other. So we're now doing a study, and I'll show you a picture which briefly in a minute, where we geographically map the cases. And you can see just by visualization exactly some insights into what is going on. And then we can use whole genome sequencing of cases. And this sounds a bit crazy, I know, especially when you have large numbers of cases. But this is becoming cheaper by the day, and machines are operating on the ground in Indonesia, but in some countries are starting to get closer and closer to the point of interaction with patients. And in the COVID outbreaks in New Zealand, we used whole genome sequencing almost in real time to guide the epidemiological work. So for example, we had ongoing patients. We had one outbreak which we were getting under control. It looked like we had an expansion of that outbreak, but whole genome sequencing showed that it was a different version of the virus that causes COVID-19. And we were able to reduce the amount of public health restrictions on the population because we knew we didn't have a widespread outbreak. So this is a long way off at the moment, but watch this space. There are ways in which we can use research at the moment already to give an idea of the future. We can also use social network analyses to understand social connections between cases and others in the community. So the paradigm that we have at the moment is of a household. We test the household, we go back to work, and we see if they've got maybe infection or disease. But the interaction between people is much more complicated than that. And in different cultures around the world, the social contact networks, the intensity of the connection between people is very much localized and contextual and context specific. So we're doing a study in New Zealand in our Maori population, looking at a different type of contact tracing, where you follow the social networks around the country. And some of them go all around the country because they move around doing different jobs for different people, for example. The next thing is the strategic application of active case finding and latent infection preventive treatment. And this is about responding to all these pieces of information and then being strategic and actually being smart in public health practice. And we've only just started to understand this in New Zealand and COVID-19 outbreaks, that we can actually use strategic thinking a lot more cleverly than we did before if we interact in real time with what the outbreak is doing. And then optimizing diagnosis. As we said before, we have to get a rapid, easily available, cheap, high-performing point of care test. Otherwise, we're going to have huge trouble for a long time. Next slide, please. So this is part of Bandung, and I've moved these cases around, and we've made this so it's very hard for you to work out where this is anyway. But just to point out, we went to one of the Puskesmas yesterday, and we said, what do you think? How are we going to bring TB down? And Pa Lura said to me, poverty. We cannot do this without addressing poverty. And you can see here's a whole lot of dwellings in the poor part. Right next door is a whole lot of bigger dwellings, presumably more wealthy. These are TB cases. There's no TB cases diagnosed by the Fiscalismus here. And there's two reasons, presumably. One is they don't have TB cases. The other reason is that they don't engage the public system because they pay for their medical care elsewhere, which is a challenge in itself. But this issue of poverty and its relationship to TB has been known for a long, long time. And it's a challenge to all of us to stand up against poverty, to give of ourselves, to do something about it, and to make a difference in society, not just about diagnosis and management. We need to engage in the deep issues of the society that we live in. And just to close the last slide, to thank everybody. I haven't got photographs of everybody. Some people would thank me for that. But just to say thank you for the collaboration over many years. I think we can be very proud of what's been done. And you are having an impact in my country and in other parts of Africa, other parts of the world as well. And I think we can be very proud. Thank you.
Thank you very much, Philip. Yeah, and for the last speaker, Dr. Panji Fortuna. I think Panji is now actively doing research on this topic that we are discussing just now. So Panji, the time is.
Terima kasih. Thank you, Dr. Riza. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. If you would excuse me, I would present in Bahasa, just so to prevent my advisor from knowing my mistakes and errors. So I'm now doing my PhD in University of Otago under the advising of Professor Hill. Jadi saya pakai bahasa Indonesia saja supaya lebih engaging, hopefully. Terima kasih. Jadi saya pada kesempatan ini mungkin akan lebih banyak menyampaikan tentang konsep-konsep ketimbang evidence-evidence. Karena apa? Karena menurut pengamatan saya, menurut pemahaman saya, memang kita pertama kali perlu memahami dulu konsepnya, dan ini banyak sekali kebingungan. Waktu saya membaca tentang public-private mix in TB, saya pun perlu waktu cukup lama untuk pinpoint, makhluk apa ya ini sebenarnya ya. Jadi sebenarnya public-private mix, dan kenapa ini menjadi topik bahasan hari ini. Mungkin tadi Dr. Bhakti sudah menunjukkan range of scope of works di RC3ID yang dimulai dari clinical works, mulai dari diagnostik, treatment, kemudian kita dilanjutkan dari presentasi Pak Philip ke case finding, dan sekarang saya masuk ke sini untuk berbicara lebih luas lagi, bagaimana hal-hal tersebut diimplementasikan. Karena di sini sebenarnya ujung tombak dari apa yang dilakukan teman-teman di laboratorium dan di clinical studies. Kalau pekerjaan itu tidak sampai ke pasien, maka se-advance apapun penelitian kita tidak akan bisa melihat prevalensi insidensi itu turun. Slide. Jadi kenapa? Saya akan mulai dari kenapa public-private mix penting. Kemudian baru mendefinisikan apa sebenarnya public-private mix. Apakah ada kalau bukti bahwa public-private mix itu memang perlu dikerjakan, dan jika ada, bagaimana kuat evidence-nya, lalu kemudian kita mau melakukan apa. Nanti saya akan tutup sedikit dengan beberapa penelitian yang sudah dikerjakan di kami di grup RC3ID, termasuk di Departemen Ilmu Kesehatan Masyarakat. Di sini ada Dr. Denny yang juga peneliti leading researcher di public-private mix di KM, selain Dr. Boni tentunya. Dr. Boni sebenarnya yang pertama meneliti public-private mix di RC3ID. Tetapi dibandingkan penelitian klinis, penelitian public-private mix ini relatif bayi ya. Dr. Bakti mungkin baru 10 tahun barangkali kita melakukan penelitian ini, dan tenaga penelitinya baru Dr. Boni dan saya, baru 2 orang. Jadi belum ada pancakaki seperti TB meningitis tadi. Baik, jadi kenapa public-private mix itu penting? Program tuberkulosis atau pemberantasan tuberkulosis sebenarnya hampir seluruhnya dikerjakan di sektor publik, di sektor pemerintah. Jadi yang menjadi ujung tombak, slide asli punten, adalah puskesmas biasanya. Jadi puskesmas, kemudian Rumah Sakit Hasan Sadikin yang juga rumah sakit pemerintah, BBKPM, ini adalah vaskes-vaskes yang menjadi ujung tombak pemberantasan penanggulangan tuberkulosis. Ini adalah vaskes-vaskes yang sepenuhnya ada di dalam sistem program TB. Nah, tetapi kalau kita lihat sebenarnya orang itu kalau sakit tidak selalu langsung mengunjungi puskesmas. Walaupun kita punya 10.000 puskesmas di Indonesia, tetapi kita juga punya entah berapa ratus ribu dokter praktek swasta, entah berapa puluh ribu klinik, saya tidak tahu hitungannya, tetapi yang jelas banyak sekali. Dan kalau kita lihat di sini, ini adalah hasil scoping review dari publikasi-publikasi di Indonesia yang menyimpulkan tergantung dari apa gejala dan persepsi orang tentang penyakit tersebut, dia akan mengunjungi tempat yang berbeda. Jadi pada umumnya yang nomor 1, pada umumnya kalau dia gejala-gejala orang-orang pada umumnya itu orang dewasa, laki-laki, perempuan, kemudian mengalami gejala-gejala penyakit yang umum, dia akan selalu dia biasanya mulai dengan self-care. Self-care itu termasuk doing nothing. This is interesting. Self-care includes doing nothing about your disease. Kemudian yang paling banyak kedua adalah membeli obat sendiri. Membeli obat baik itu dari apotek, dari toko obat, dari supermarket. Kemudian dan baik obat itu apakah obat kimia dalam tanda kutip ataupun obat herbal. Itu adalah pertama yang biasanya orang Indonesia kerjakan kalau dia sakit. Kemudian kalau itu tidak sembuh, baru dia mengunjungi biomedical service providers. Ini pada umumnya. Jadi baru ke dokter setelah agak parah. Makanya tadi ditunjukkan 2 kali oleh Prof. Reno dan Prof. Philip, hasil studi yang dikerjakan Dr. Boni dan kawan-kawan, itu orang yang mempunyai gejala TB pada umumnya atau mediannya 50% orang yang didiagnosis TB itu melakukan 7 kali kunjungan sebelum dia didiagnosis TB. Dia shopping dulu gitu. Jadi window shopping, ini sakit apa, setelah 50% setelah kunjungan ke-7 diagnosis tuberkulosis. Nah, kecuali yang kelompok 2 ini adalah ibu-ibu dengan anak, biasanya kalau anaknya sakit, dia nggak self-care. Yang didahulukan adalah ke dokter dulu. Nah, tetapi kalau untuk penyakit-penyakit tertentu yang ada persepsi supernatural gitu ya, itu dia biasanya langsung mengunjungi pengobatan tradisional atau alternatif. Nah, tentunya ini juga bisa menjadi komplementari atau suplementari dari pengobatan biomedicine. Jadi yang pertama adalah poin di sini, orang sakit tidak selalu langsung mengunjungi biomedical services. Dan termasuk di sini adalah apotek dan lain sebagainya ya. Dan di sini juga ada 2 sektor yaitu public dan private. Nah, kemudian kalau di slide berikutnya kita lihat sepenting apa private sektor di pengobatan TB, Astri slide. Nah, untuk orang-orang dengan gejala tuberkulosis juga sama ternyata. Jadi ini hasilnya sama kesimpulannya dengan apa yang kami lakukan dengan Dr. Boni di Kota Bandung. Ini dikumpulkan dari berbagai macam data di Indonesia. Kalau kita lihat di sini, orang-orang dengan gejala tuberkulosis itu pertama kali datang kebanyakan di yang warna biru ini ya. Jadi lebih dari 50% itu datang ke sektor swasta. Sektor swasta itu ada level 0, level 1, level 2. Level 0 adalah tempat-tempat seperti apotek. Jadi self-care itu, healing. Nah, self-care dengan membeli obat di apotek. Baru sebagian kecil 20% itu mengunjungi level 1, level 2. Jadi dokter-dokter sekalian nanti level 1 atau level 2 praktek mandiri atau praktek di rumah sakit itu level 1, level 2. Hanya 20% orang sakit TB pertama kali memilih dokter praktek mandiri ya. Sedangkan yang pertama kali berkunjung ke fasilitas publik itu sebenarnya tidak terlalu banyak, 20%. Sedangkan ironisnya fasilitas diagnostik untuk tuberkulosis kebanyakan adanya di satu fasilitas publik dan fasilitas swasta yang level 2. Bahkan di level 1 pun tidak ada. Jadi artinya apa? Ini banyak sekali missing opportunity yang ditunjukkan tadi di grafik Dr. Boni, missing opportunity untuk diagnostik. Nah, kemudian dia berlanjut terus ya, setelah 7 tadi ya, 7 kali kunjungan, dia baru akhirnya terdiagnosis. Di mana kebanyakan? Pada akhirnya kebanyakan terdiagnosis di sektor publik. Jadi memang dia jalan-jalan, akhirnya dirujuk juga ke puskesmas, sehingga sekitar 60% akhirnya terdiagnosis di sektor publik, tetapi masih ada kok, masih banyak yang terdiagnosis di sektor swasta, yaitu sekitar 30%, dan pada akhirnya sekitar 45% itu berobat di sektor swasta. Masalah tidak? Enggak masalah sih berobat di sektor swasta, kalau pengobatan di sektor swasta ini memenuhi standar pengobatan TB yang kita pegang sekarang, mengikuti ISTC ataupun paling tidak guideline nasional ya. Tetapi dari temuan-temuan kami, ternyata tidak semua dokter praktek mandiri atau rumah sakit bahkan itu mempraktekkan DOTS. Bahkan kalau dokter praktek mandiri kami masih menemukan pengobatan dengan regimen yang parsial gitu. Hanya ngasih INH dan rifampicin saja misalnya begitu. Jadi masih ada yang seperti itu. Yang parahnya adalah the vast majority, sebagian besar 60% dari pasien-pasien yang datang ke fasilitas swasta itu tidak terlaporkan. Tidak dilaporkan ke dalam sistem pencatatan. Kenapa itu jadi masalah? Itu jadi masalah karena kita tidak pernah tahu ini pasien akhirnya bagaimana. Sembuh atau enggak, atau meninggal, atau berhenti berobat, atau jadi MDR. Kita tidak tahu. Nah ini sebagai ilustrasi kenapa public private mix penting, karena private sector itu kebanyakan unregulated ya. Regulasinya hanya izin praktek lah, izin membuka klinik. Tetapi bagaimana mereka melakukan praktek itu largely unregulated. Kemudian dia juga banyak yang tidak melaporkan. Oke, slide. Nah, jadi baru terpikir nih ya 30 tahun yang lalu sektor swasta itu tidak boleh dibiarkan. Karena walaupun TB adalah masalah masyarakat, masalah sosial, tetapi mau tidak bisa disangkal sektor swasta terlibat sangat aktif dan perannya sangat penting. Jadi disebutkanlah ya ini WHO dan dari UPLEKAR, dia bilang apa sih public private mix adalah a comprehensive approach for systemic involvement of all relevant healthcare providers in TB control to promote the use of ISTC and achieve national and global TB control targets. Yang kedua, partnering with all relevant healthcare providers, public and private, voluntary and corporate, formal and informal, so that they can undertake according to their capacity and skill one or more tasks related to delivering high quality TB care. Kenapa saya mulai dari menunjukkan definisi ini? Karena menurut saya nih, apa sih yang harus dikerjain sebenarnya? Definisinya sangat-sangat luas. Coba slide berikutnya. Kalau dibuat satu model yang generik, kira-kira bagaimana sih public private mix itu bekerja? Jadi yang paling penting sebenarnya kata kuncinya adalah mix, campuran. Jadi campurannya harus seperti apa? Siapa mengerjakan apa? Ini yang menjadi konsep atau sentral dari konsep public private mix. Secara umum biasanya yang paling atas di sini adalah tentunya Kementerian Kesehatan dan dan Dinas Kesehatan setempat. Mungkin saya ingin mengambil kesempatan di sini karena di sini saya lihat ada dari RSAS, residen yang juga nantinya akan mungkin praktek swasta gitu ya, bahwa pada program tuberkulosis yang memegang stewardship atau pengaturan adalah Kementerian Kesehatan. Nah, kemudian di sini ada basic management unit, jadi klinik atau rumah sakit, baik itu swasta maupun pemerintah yang terdiri dari banyak tempat. Nah, ini pada umumnya kita bisa melihat bahwa pemerintah itu tugasnya quality assurance, supervision, monitoring. Kemudian ini juga sama. Kalau ngelihat sini gini sih gampang. Tapi pada prakteknya slide, ternyata dari banyak tempat, slide 3, banyak negara yang mempraktekkan public private mix atau pernah mempublikasikan hasil public private mix, ternyata tidak ada satu model yang sama di mana-mana. Jadi fungsinya bisa bermacam-macam. Ya, misalnya di sini siapa melakukan apanya, pemerintah biasanya bisa memberikan financing. Kemudian bisa ini ya warnanya ya, pemerintah di sini bisa memberikan financial support, material supply, kemudian technical assistance. Sedangkan NGO kemudian klinik itu biasanya hanya melakukan pekerjaan yang dia lakukan saja gitu, mengobati dan lain sebagainya. Tetapi bagaimana mengaturnya? Macam-macam ternyata. Ada yang membuat kontrak formal. Ada yang membuat kontrak informal. Kalau kontrak formal itu buat MOU, Anda mengerjakan ini, saya mengerjakan ini. Kalau ada yang prestasi, apa konsekuensinya? Kalau informal hanya lewat WA aja. Dok, punten ya, ada kasus tolong dilaporkan. Ada yang seperti ini, organisasi tanpa bentuk aja. Jadi segala macam masuk berkumpul di situ, dibuat satu konsorsium yang dibilang ini adalah konsorsium public-private mix. Dan kita sekarang mengerjakan semuanya. Jadi di Indonesia sekarang ada yang namanya District Public-Private Mix programnya, di mana setiap kabupaten kota itu diharuskan oleh pemerintah membentuk tim District Public-Private Mix. Yang salah satu komponennya adalah Kopi TB. Prof. Ida, Dr. Rudi pasti sudah pernah mendengar. Koalisi Organisasi Profesi Indonesia untuk Tuberkulosis. Apa kerja Kopi TB? Apa kerja DPPM? Tim DPPM? Apa dok? Apa Prof? Enggak tahu. Banyak sih dikasih apa namanya item-itemnya oleh pemerintah. Tetapi pada prakteknya tidak ada yang memaksakan atau memastikan bahwa pekerjaan itu akan dikerjakan oleh orang atau organisasi-organisasi yang baru dibentuk ini. Jadi ini satu konsep dan ide yang sangat kompleks, penting, tetapi dalam implementasinya ternyata sangat beragam. Variability-nya sangat-sangat tinggi. Kemudian slide. Dan satu lagi yang paling penting adalah ini saya ambil dari WHO Public Private Mix Toolkit yang diterbitkan tahun 2010. There is no one size fits all public private mix approach. Seperti tadi di slide sebelumnya ya, ada berbagai macam model dan itu tidak bisa sih sebenarnya. Misalnya Kota Bandung memilih model A gitu, bahwa itu akan berhasil dikerjakan di Jakarta. Atau bahwa di Gambia atau di Kenya menggunakan model B, itu belum tentu berhasil di Indonesia. Slide. Walaupun demikian, kalau dari beberapa publikasi yang ada, ini sekitar 64 publikasi tahun 2015 ya di review, publikasi public private mix menunjukkan hasil yang menggembirakan sebenarnya ya. Jadi dari semua yang dilaporkan, public private mix itu bisa meningkatkan utilisasi DOTS. Tentu begitu ya, karena mungkin senior-senior di sini yang bekerja di rumah sakit swasta mungkin tadinya tidak melakukan DOTS. Kemudian di-approach sama pemerintah, diedukasi, diadvokasi supaya mengaplikasikan pendekatan DOTS di rumah sakit swasta. Kalau di Indonesia konsepnya adalah internal linkage. Jadi unit-unit yang ada di rumah sakit, radiologi, laboratorium, poliklinik, penyakit dalam, pulmo, itu di linkage supaya semuanya mengerjakan satu standar operational prosedur untuk diagnostik, manajemen, dan pelaporan. Kemudian meningkatkan case detection. Saya tidak tunjukkan angka-angka di sini. Kenapa? Karena tergantung konteksnya, hasilnya berbeda-beda. Ada yang bisa tinggi banget gitu ya, ada yang cuma sedikit aja, dan tidak semua mengukur hal yang sama masalahnya. Bisa memperbaiki treatment outcomes, mengurangi dropout, mengurangi kegagalan pengobatan. Yang paling penting adalah memperbaiki referral. Jadi lebih jelas dari praktek mandiri itu dirujuknya kemana. Dan ada beberapa yang kan bisa mengurangi cost. Tetapi sekali lagi ini dari sekian sedikit publikasi ya, 63 publikasi saja tahun 2015. Dan yang paling penting menurut saya adalah publikasi-publikasi ini kebanyakan sifatnya pre and post. Satu, dan kedua biasanya evaluasi proses, bukan evaluasi impact. Jadi evidence keberhasilan public-private mix yang sifatnya robust, kalau di kita level 4 dengan randomized trial sebenarnya sangat minim. Ya, selanjutnya slide. Ada masalah lain, PPM itu mahal. Tahun 2018 kami melakukan implementasi district based public private mix, 1 miliar habis hanya untuk mencari data dan melakukan training 1 tahun, 1 miliar. Dan itu tahun berikutnya nggak berlanjut. Dampaknya apa? Kami tidak bisa mengukur. Itu di Kota Bandung. Dan hanya sebagian puskesmas, hanya sebagian rumah sakit. Tidak murah. Jadi teorinya sih enak, tetapi perlu diduitin juga. Nah, sekarang di Kementerian Kesehatan ada dana khusus alokasi dari Global Fund untuk private mix dan CID untuk TB di private sectors. Kelemahannya apa? Uangnya ada, tetapi begitu uang dari donor ini berhenti, kemungkinan besar kegiatannya akan berhenti juga. Kemudian private sektornya akan terbengkalai lagi. Political commitment may be lacking. Ini biasanya sangat lokal sifatnya. Puskesmas itu kekuatan advokasinya berbeda. Ada petugas puskesmas yang sangat rajin, ada kepala puskesmas yang sangat rajin, tetapi ada juga yang peduli nggak peduli, biarin aja deh ya. Dan kedua, political commitment tentunya dari private sektornya juga. Karena pertanyaannya yang paling penting adalah apa sih insentif untuk private sector untuk mengikuti program TB nasional? Dari JKN udah ada inasi bijis, nggak ada uang lebihnya saya rasa ya. Kalau mendeteksi TB nggak ada ya Prof ya? Dok, kalau mendeteksi TB nggak ada. Apalagi di private di praktek mandiri. Kalau saya melaporkan TB, saya dapat apa? Dapat SKPID teorinya mah ya. Memang sekarang sudah ada sih percobaan atau trial untuk mendapat SKPID. Tetapi pertanyaan nanti berikutnya Prof, bagaimana ID membuktikan bahwa orang ini memang mendiagnosis TB, nggak bohong-bohongan gitu kan ya. Jadi nanti akan ada masalah yang ini nih, governance. Governance mengatur atau mengorganisir private sector itu sangat sulit karena sangat beragam. Ukurannya sangat besar, kapasitasnya sangat berbeda. Jadi ini akan menjadi tantangan sendiri dan apa yang terakhir tadi yang saya sampaikan bahwa berhasil atau nggak berhasil, saya agak ragu sebenarnya ya, karena ada publication bias. Kalau gagal, kemungkinan besar tidak akan dipublish. Jadi ya yang dipublish pasti yang berhasil aja. Saya akan lewat saja ini skip, banyak sekali constraint-nya, slide. Dan yang paling penting lagi tadi sustainability. Ini ada satu publikasi tahun 2016, Public Private Partnership di Timika di Papua. Mereka melaporkan model baru di mana private sector bukan saja sebagai healthcare provider tapi juga penyandang dana karena mereka punya Freeport di sana. Jadi melaporkan di sini objective to describe a successful partnership. Dia bilang successful partnership. Tapi kalau saya Google ini tahun 2002 kasus TBC di Mimika masih tinggi sebenarnya. Jadi ya oke, partnership-nya successful, ada funding dari private sector, tapi how impactful? Jadi satu sustainability karena Freeport-nya udah diakuisisi, saya nggak tahu yang masih mendanai atau enggak. Yang jelas public private sector tentunya public private mix tentunya bukan sufficient condition untuk pemberantasan TB. Tetapi for sure saya yakin ini necessary. Karena private sector kalau tidak diatur dan tidak dilibatkan dalam TB control, tentu kita akan kehilangan bagian besar dari penanganan TB di masyarakat. Slide. Nah, tentu saya singkat saja di sini, yang kemungkinan besar yang harus kita lakukan adalah membuat public-private mix policy itu sangat konteks spesifik. Di sini tadi Prof. Philip menyampaikan ada public health approach, ya. Kalau di teman-teman yang sudah lewat IKM sudah tahu analisis situasi. Ini sangat penting. Kalau menurut WHO, analisis situasinya harus dilakukan di level nasional. Menurut saya, analisis situasi ini harus dilakukan di level terendah di mana kebijakan PPM itu bisa dilakukan secara unik. Misalnya di level puskesmas kalau perlu. Karena satu puskesmas dengan puskesmas lain kondisinya bisa berbeda, stakeholder-nya bisa berbeda, strength dan weaknesses-nya bisa berbeda. Jadi kita mungkin kebijakan nasional yang ada aja sekarang nggak akan cukup untuk memastikan kebijakan PPM ini bisa berjalan. Dan yang ini yang paling penting menurut saya. Sejauh ini kita berdiskusi dengan Dinas Kesehatan, dengan Kementerian Kesehatan. Kita selalu bicara public-private mix. Tapi what kind of mix? Siapa mengerjakan apa itu suka nggak jelas. Pokoknya mix saja. Jadi campur aduk gitu ya. Padahal kalau kita mau bikin es campur aja, campurannya harus jelas gitu kan. Berapa banyak sekoteng, berapa banyak apapun lah. Dan kita harus melihat ini nih, apa kapasitas program TB untuk memantau, kemudian mendukung, dan mengimplementasikan atau mengenforce kebijakan-kebijakannya. Di Dinas Kesehatan itu ada 1 orang wakil supervisor yang kerjaannya hanya tuberkulosis, hanya 1 orang. Biasanya dibantu oleh mungkin 1 atau 2 orang petugas data. Dan dia harus mengurus 1 kota. Di Bandung 2,5 juta orang, program TB-nya diurus oleh 3 orang. Di setiap puskesmas ada 1 perawat TB biasanya, dan biasanya tidak lebih. 1 puskesmas itu mengurus 30.000 sampai 50.000 orang tergantung wilayah. Apakah dia akan mampu untuk mengejar setiap dokter praktek mandiri, dok sudah lapor belum begitu kan ya? Kemudian dokter praktek mandirinya mengeluh, Bu ini saya ada pasien harus gimanain. Hanya ke 1 orang yang ada di puskesmas itu sendiri saja mungkin nggak akan bisa. Jadi ini akan menjadi tantangan sekali, makanya kami di RC3ID dan Departemen Ilmu Kesehatan Masyarakat mulai menggarap ini di penelitian. Slide terakhir, ini adalah slide. Ini adalah beberapa publikasi yang sudah keluar dan berkaitan dengan public practice. Tadi yang sudah grafiknya ditunjukkan 2 kali ya, Dr. Boni melihat patient pathway dan kita memberikan bukti bahwa private sector itu penting karena 50% itu 7 kali berkeliling dulu di private sector sebelum dia didiagnosis. Kemudian kami ini juga Su dan Dr. Boni melakukan feasibility study untuk active case finding dan juga ini, maaf ini yang Dr. Denny ya baru sekali keluar dan ini kita lanjutkan ke sini. Sekarang kita melakukan 1 randomized control untuk membuktikan ya apakah memberikan 1 intervensi itu bisa memberikan impact setidaknya meningkatkan kontribusi private sector untuk pelaporan kasus-kasus TB. Ini sangat-sangat pragmatik trialnya dan juga berbasis masyarakat, bukan berbasis klinis, bukan berbasis individual pasien. Dan tentunya saya pribadi sangat senang ya dengan adanya ini karena ini public health banget gitu ya. Jadi kalau di klinis ada randomized control trial, kalau di public health lebih baik menggunakan cluster randomized trial. Jadi randomisasinya di tingkat puskesmas. Dan ini dari Departemen IKM, saya mohon izin angkat di sini, Dr. Denny juga melakukan penelitian public private mix dan berfokus kepada ya kesiapan ya dari private sector untuk dilibatkan ke dalam public private mix. Ini hanya saja yang kita baru mulai di sini. Jadi pintunya masih terbuka lebar, kesempatannya masih terbuka lebar, tantangannya juga masih banyak, fundingnya yang masih kurang. Gitu ya. Tetapi untuk melengkapi dan menutup rangkaian kuliah ini, bahwa saya ingin berterima kasih ke Dr. Bakti yang sudah mengakomodir penelitian tuberkulosis dari hulu ke hilir, dari klinis sampai ke public health, from bench to bedside to community begitu. Dan di sini adalah salah satu aspek community dari penelitian TB yang kami lakukan. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Panji. Thank you very much. And I'd like to invite all the speakers to come forward. Maybe for some discussion. Mungkin karena waktu kita batasi mungkin 3 pertanyaan. Kami persilahkan. Iya, silakan.
We know that Prof. Reynolds mentioned that there are new drugs for TB, and we know that funding affects TB outcome. And but with the limited fundings, we have to buy expensive new drugs. Could you please give us any insight about how other countries or other contexts give overcome patents for new drugs? Because we cannot wait for another 20 or 30 years until the patents ends. And any tips on how to overcome patents rights in middle and lower income countries? Thank you very much.
It's a good question. I'm not sure I'm an expert here. In my understanding, these drugs are centrally supported, let's say, and the TB programs in certain countries can be more vulnerable because they, for a larger proportion, are funded externally by Global Fund or whatever. Obviously, there are. So I think for the new drugs, I'm not sure. Let's say I'm just not sure. Let's say whether Indonesia has to make a choice. Okay, we go for rifapentin for latent TB, and then we cannot buy expert, or the other way around. I just don't know.
Whether speaker will bagaimana? Iya, sebenarnya bagaimana kita bisa menyediakan obat yang baru-baru ini lebih murah dan lebih tersedia buat semua orang.
Yes, yeah, it's a difficult thing. I think it's not only in our capability as a doctor or a health worker. I think example in India, where the drug can be very cheap. They are active not only in the industry but also at the law. At the law, they make their own national law, so they can overcome or what do you call it, shortcut patent somehow. So it's really a very difficult. We have to work with other discipline like the law. Thank you.
Ya, sedikit menambahkan aja, just to add a little bit to the answers. This may not be, well, this may be relevant with our experience in COVID, with the availability of vaccines for lower and middle income countries in an advanced market commitment scheme, so AMC. So if, and we know TB is a high burden, well, a lot of countries have a lot of these TB diseases. So we're talking about many million people that will require some sort of medications. I think this something that, well, some people can think of is an AMC-like scheme. So we can, apa sih namanya, pre-order ya, make an advanced, yeah, it is what it is, an advanced market commitment, saying to the pharmaceutical industry that, you know, we will commit to buy this many billion doses of TB drugs, and so that you can be sure that you can produce this many billion TB drugs at a lower cost. Karena this is economy of scale. Kalau kita membuat 1 juta tablet, itu ongkosnya lebih mahal daripada kita membuat 10 juta tablet. Karena ada overhead cost-nya tetap, tapi dia disebarkan ke lebih banyak tablet begitu kan. That's how advanced market commitment works. Kita meyakinkan bahwa mereka bisa membuat sekian banyak obat untuk memastikan mereka bisa menghasilkannya dengan harga yang lebih rendah. So that's one thing that we may consider and we may advocate to the policymakers. Thank you.
Thank you, Dr. Panji. Cukup? Makasih. Ada pertanyaan dari floor, silakan.
Thank you very much for the opportunity. I am Adriana from Faculty of Medicine, Universitas Indonesia. It was a very amazing session, so thank you for the very insightful information. I have 2 questions. The first one would be, I think the program to do neighborhood contact tracing is very good, but at the same time, I wonder if there is any solution to ensure the sustainability of the program, considering that the cadre, which are the front line of the tracing program, is known to be dwindling in number. So I would like to ask if there is some solutions that have been brought upon by the Universitas Padjadjaran to ensure that it can be reduced in effect and therefore ensuring the sustainability of the program. And the second question would be, in terms of the tuberculosis intervention, how do we apply planetary health concept into the picture? Because I think currently the concept of planetary health is growing, and perhaps in terms of environmental health, there is also something that we can do to ensure better prevention of tuberculosis. Thank you.
Okay, thank you. Maybe Philip, you.
Thank you. Very difficult questions. I think then the question is, what every time you do a research project on something, how do you translate that into practice, and do you plan for that? It's very difficult because it has to be the responsibility of the national program to adopt new intervention. But there is some responsibility for those doing research to be trying to help with that process of translation into practice. There's obviously no way that a small research fund for a project can then suddenly expand its funding for the whole country implementation. But I think the principle is that you shouldn't be studying something for too long that isn't able to be translated into practice. If it's of no use and never going to help, then you have to think to yourself, is this really sensible? It's enjoyable for research maybe, but is this actually sensible to do this? And we shouldn't do it for too long. But I think what the message I was trying to place was that, inspired by some things we learned from COVID and from things we're already doing, if we're going to see a big drop in TB, we need to do some things completely differently. And that's going to require everybody to be engaged. And obviously the things like CADA's dropping numbers and so on but is important to be taken into account. But in the first instance, there needs to be a complete change in how everything is funded in TB. And then the whole linkage, as you were implying for the second point, the whole environment around households is needing to be addressed to improve the risk of infection. And that whole issue is massive. So it's a huge challenge, certainly way beyond the ability of a small research project to influence, but acknowledge absolutely is crucial, yeah.
I may just some food for thought. I think sustainability is certainly an issue, especially bridging from research to implementation, because we have dedicated funding for research that may not be, or very likely will be unavailable for practice by policymakers in the program. But I think as academics and researchers, we can also play the roles of advocates. We have relatively more access to evidence, and we can communicate that evidence. And among other things that I can think of at the moment is the best practices or other practices for sustaining programs. I think one of the best programs that we can learn from is HIV, because HIV has this massive funding from all over, from so many stakeholders. And one thing that I think it interests me is the United funding model. Have you ada yang pernah dengar United funding? So among other things, what they did was they mengutip ya, assess $1 for each domestic flight tickets in Europe. Jadi $1 dari tiket penerbangan domestik itu ditambahkannya, diambil untuk pendanaan HIV/AIDS, untuk pendanaan United, which is very cheap. $1 from I don't know how many $100 ticket kan ya. And this kind of funding model has been done in Indonesia. For example, bulan dana PMI misalnya ya. For every movie ticket that you buy, you also have to buy another ticket cost 5,000 rupiah untuk bulan dana PMI. This kind of funding models needs to be considered, and moving from the reliance of donor funding, which is very, very volatile, USAID, Global Health, Global Fund, to more independent alternative funding sources. But yeah, and I think we as academics and researchers can advocate those, presenting the evidence to policymakers, convincing them. That's the most important thing, is convincing policymakers that this thing will work and will help them achieve their objectives. Thank you.
Enough? Okay, thank you. And then there's a question from the Zoom chat. Maybe Reinhard can help.
Yeah, so one is a question, since COVID affects all aspects, including for TB patients, if there is a domino effect for the TB patients during the pandemic. I don't think there's a single answer to that question. I showed you the example of Indonesia versus Uganda, and the effect of COVID in Indonesia was much stronger than in Uganda. And so the context, I think, is very relevant. So how was the epidemic dealt with? That's one. And second, of course, patients are very different. Some will be less affected, and some aspects will be less affected. So I think it's difficult to say that there's a domino effect, but what the data have clearly shown, that there has been a massive effect, and that we are put back in time, let's say, after years of progress, that there's more deaths, and that we will have higher sustained higher incidence for some years to come in Indonesia. The second question is about TB therapy and alternative drugs, indeed. So this is a question about rifapentin. So a 4-month regimen with rifapentin, whether that could already be put into practice. Well, yes, there's data suggesting that a 4-month regimen of rifapentin is equally effective as a 6-month regimen. I think there's a lot more shorter regimens to come. And I also think that it's not going to be one size fits all, so that we used to treat every patient, whether it's very severe TB meningitis or whether it's very severe cavitary TB or whether it's mild disease, with the same 6-month regimen. I think that's going to change. And based on the severity of disease and some other factors, I'm sure not too long from now, patients will be treated with shorter regimens. Rifapentin is an option, but rifapentin is expensive. So if you have to balance your investments, it may not be at this point be the best value for money to go for a much more expensive regimen.
Thank you, Reinhard. And then maybe the last question will be answered by Panji, also from the Zoom.
Thank you. The first question is how to maximize collaboration, intersectoral collaboration, so that we don't have double data or double entry of data. That's a very good question, but I think the answer is not very hard. We have now information technology. What's harder is, well, exactly the question is to to maximize intersector collaboration, because well, oftentimes these different sectors works in silos. So they work for their own purposes. They have their own tupoksi, tugas pokok dan fungsi, which is the keyword in bureaucracy. Most of the time, if you ask, why did you not collect this? Because that's not my tupoksi. So I think there's a lot of reform that is required in the working of the organizations that are involved. Yeah. And this is not an easy thing to do, but we know what to do, but it's a lot harder to actually do it. And then the second question is, I'm interested in cluster control trial. Can you explain it more completely? Well, I can in one semester probably. So, but to be brief, to compare it with randomized control trial in the clinical sense, randomized clinical trial, the level of randomization is different. So in a randomized control trial, the unit of randomization and the unit of analysis are usually the individual patient, the individuals. But in a cluster randomized trial, the level of intervention and the level of randomization as is at the cluster level or at the group level, for example, classroom or puskesmas or clinics. But the analysis can be done at the individual level. So I guess that's among the most important difference in cluster randomized trial and randomized clinical trial. But we can discuss that more in outside of this forum. Thank you.
Thank you, Panji, and to all speakers, I'd like to extend my thank you. That today we have the very fruitful meeting, and so with many insights, especially for clinicians. So by that, I'd like to conclude this meeting. And then thank you very much again, Professor Reinhold van Krevel, Professor Philip Hill, Dr. Bhakti, and also Dr. Panji for the interesting topics that is delivered. And then I give the session to Intan.
Well, everyone, let's give one round of applause again for all the guest speakers. And thank you everyone for attending the meeting and also for everyone by Zoom. I hope we can get a lot of and learn about many things and get motivated to increase TB care in Indonesia especially. And thank you. Thank you again for the speakers, and I wish you all a good evening, and Assalamualaikum warahmatullahi wabarakatuh. If you have other questions or would like to discuss, maybe you can approach the speaker.